Good morning, everyone, and welcome to our webinar, Proving the Point, the Evidence Behind Supported Standing. My name is Mary Ann Girardi. I am one of the clinical education specialists here at Ultimate Medical. I am an employee of Ultimate Medical. I'm a physical therapist and an assistive technology practitioner. I've been working for a very long time in pretty much every setting, peds and adults, and all with neurodisabilities. All right, I did try orthopedics, but that lasted about 6-8 months. Today, we're going to be talking about the evidence behind supported standing. We've used supported standing, especially in the pediatric population, for generations. And there's not a whole lot of evidence behind the use, but there is some. Today, our learning objectives are going to be describe the levels of evidence and identify factors that may affect their use in clinical practice, identify a minimum of 3 research articles that support the use of supported standing for pediatrics, identify a minimum of 3 research studies that support the use for supported standing for adults. So it's not just for kids, it's for adults, and it's not, we're going to find when we go through some of the evidence that we think it's mostly for cerebral palsy and spinal cord, but it has implications with research evidence that supports the use for other populations. We're going to talk about some of them. Well, first, let's talk about the levels of evidence. And the strongest evidence is clinical practice guidelines and health technology assessments. The next level is systematic reviews and meta-analysis. And these are both studies that look at individual studies and form opinions from them. Then we're going to go down to randomized controlled trials. With randomized controlled trials, you usually have a very large number of participants to get good statistical results. Unfortunately, the studies for standing do not have large numbers, and getting statistical significant results is a little more difficult. The next level is controlled clinical studies, where they do an intervention and test pre and post, retrospective and cohort study and prospective cohort studies. So they take a population and they either go back and look through their clinical data. CPUP does this a lot, the Cerebral Palsy Follow-Up Program. They go back the data for the individuals. A prospective cohort study is where you're going to take a group of individuals and follow them forward. Case report and case series, and expert opinion. So when we're thinking about evidence-based practice, we need to realize that evidence-based practice is not just the research articles. It's the best available evidence. It's also the clinical expertise and experiences of the individual doing the therapy or the intervention. We all have lived experiences, and we found things that work and don't work. An example of this is I live in the Boston area, and we're talking wheelchairs, and each of the wheelchair salesperson, you could tell which chair it was because they use the components for a wheelchair that they have the experience with the best results. We do that in clinical practice. We all have different things that we go to that we know have worked, and we have good results with them. We also need to take into account the patient's preferences. We all know when you're working with individuals, if they don't buy into what you're doing, and if it doesn't fit into their lifestyle and who they are and what their goals are, they're not going to use it. So you could have the best evidence, research evidence, the best experience clinical, but if the person doesn't want it, like it, or accept it, you're not going to be able to use it. And you need to take that into consideration when you're choosing interventions. When we think about evidence, the lowest level of evidence is surveys. And what we think about with standing is what the consumers actually believe standing is doing for them. So we're going into the patient's preferences, the patient's goals. 65% believe it'll improve their circulation. 64% say they have improved well-being. Along that, they comment on sense of freedom, being my own self. 59% feel it reduces tension and stiffness. we find that spasticity and range of motion and contractures can be accommodated and assisted with supported standing. 41% feel it prevents deformities. If you go on our website, there's another whole topic, a whole hour lecture on preventing deformities and how they form. 41% it feels it improves bone density. We know bone mineral density is important to prevent fractures and secondary impairments from those fractures. 31% feel it improves respiration. They're able to breathe better. They're able to get more air into their lungs. They're able to feel better. 24% it facilitates activity. And those of you who've heard my talks before, I don't know whether it facilitates activities because of the actual mechanical positioning that they're in, or because of their improved well-being. If you feel better about yourself, you're going to want to participate more. And 18% says it reduces the risk of developing ulcers. We all know with individuals who have been impaired for a long time and unable to change their position are at high risk. Also, we won't go into the details of pressure injuries, but being able to change your position, and these people feel that using a stander can help. Excuse me. So what does the evidence say? What do the research studies that are out there and available now say about using supported standing? Well, first we're going to talk about bone mineral density. We said that bone mineral density is important to prevent fractures. We know that you need to maintain 1 gram per centimeter squared of bone mineral density to reduce your risk of fractures. Below that, the risk of fractures becomes significant. In a retrospective study of 536 children with GMFCF levels 1 to 4. Okay, so think of it, GMFCF levels are gross motor function classification scale. Level 1 are the fairly independent ones, level 5 are the totally dependent. So this study actually looked at children across the whole spectrum, not just level 4 and 5, which most of the studies we'll talk about today are 4, 5, and some 3. What they found in the retrospective study, looking back, was that the children who used supported standing regularly had a 4-fold reduction of fractures than the children who did not. There was a study done that compared the frequency of fractures with typically developing children and children with motor impairments. And what they found was that the frequency of fractures was the same. The difference was the level of trauma. And children who are mobility impaired have higher frequency of low-level trauma fractures than children with typically developing children. And they're usually getting dressed, rolling over, being positioned. But they found that children who use standing regularly had a 4-fold decrease in the risk of these fractures. So the first study we're going to look at, to me, it's a very important study because even though it was done in 2006 and it's never officially been published, it was presented at the American Academy of Cerebral Palsy and Developmental Medicine conference. And it's the first study that looked at bone mineral density in non-ambulatory children. There were 11 non-ambulatory children. The mean age was 15 years old. They stood, or the goal for standing was 2 hours a day, 5 days a week. They measured the bone mineral density in the calcaneus of the wrist. One of the goals of this study was to prove that weight bearing doesn't increase bone mineral density in non-weight bearing bones, hence the wrist. After 6 months, they found an increase in the calcaneal bone mineral density. The average standing was more than 7.5 hours a week, so an hour a day. What they found was when the standing stopped, the study was actually done in a residential school. So when the kids went home for vacation and they came back, they found they had a decrease of bone mineral density. What we need to remember, any of the benefits of standing are both time and frequency dependent. The amount of time you're standing per day, it can be cumulative, it doesn't have to be all at one shot, and how many days a week you stand. And just like going to the gym, When you stop standing, you lose the benefits. So the next study we're going to talk about is with spinal cord. 13 male spinal cords, mean age of 37. 4 did standing exercise and body support weight treadmill walking. 5 did standing exercise and customary rehab. The standing was done with standing frames. And 4 did immobilization. They started it 1 to 4 weeks post-injury. The people who were immobilized, which in a recent trip to Europe, I found that it's in some sections of the UK, immobilization for the first 8 months is standard care. You don't do anything for the, first 8 weeks, which I find unusual, but the people who were immobilized lost 6.9 to 9.4% of their bone mineral density. The people who were standing or standing and walking only had a moderate loss or a moderate increase in bone mineral density. What we know about immobilization or illness, acquired injury, and immobilization and bone mineral density is you lose the greatest percentage of your current bone mineral density during the first few months. So this next study, again, SCI, spinal cord, 54 individuals with a mean age of 35. 27 of them participated in supported standing 1 hour a day, 5 days a week. 27% did not stand at all. They started at 8 to 12 weeks post-SCI, post-injury. They found in the first year that the standing group lost 9.62% of their bone mineral density, while the non-standing group lost 24% of their bone mineral density. We also know, they looked back at 2 years. So remember I said you're going to lose the greatest percentage in the first few months of the injury. After 2 years, the standing group was able to maintain their bone mineral density above that critical 1 gram per centimeter squared, where the non-standing group fell below that. So by initiating standing as soon as possible, and even in this study, 8 to 12 weeks, they've already had a great percentage already lost. So it's preventing further reabsorption. Now let's look at kids. We think of, I know I've been standing kids for lots of years, and we just knew it was good for them. We got them up and standing. We didn't know the times. Back then, there were no systematic reviews telling you what the dosing should be. In this group, there were 24 GMFCFs level 4 and 5. So the kids who need assistance or are totally dependent, they were ages 4 to 18. 13 stood an average of 30 minutes a day. 11 had no standing at all. At the end of the study, they found that the standing group had a higher total bone mineral density, and the non-standing group had higher reabsorption factors. What happens when you're not weight bearing, you're not stimulating the mechanical receptors within the osteoblasts to maintain or produce more cells. What happens is your levels of sclerostin increase, which inhibits bone growth. So you lose more, your bone mineral density is reabsorbed. I like this study because we've seen children with cerebral palsy are an average of 2 inches shorter than their typically developing counterparts. And this study not only looked at standing and bone mineral density, but it looked at standing and growth. So they had 12 GMFCF level 5, so the kids who are totally dependent, and 6 typically developing children, all around 3 years of age. So around 3 years is a period of rapid growth and a time to build bone mineral density. So group A had standing exercises and standing for 2 hours a day, 5+ days a week. Group B had conventional PT and standing for only 20 minutes a day, 2 to 3 days a week. So we're looking at the duration, an increase, significantly threefold increase in duration, and an increase in frequency. So the amount of time we're stimulating the osteoblast with weight bearing. And what they found after 6 months was that the group who stood longer, more frequently, had an increased trend in their bone mineral density. The group who stood less frequently for less duration had a decreased trend. But they also compared the length of the femur with typically developing children. So what they found was that the typically developing child's femur length increased 39%. The group who stood for longer duration more frequently increased 30%. The group who stood for less duration, less frequency, 20%. So by having less duration, less frequency of standing, we've almost cut the growth of the femur by half. Again, we're looking at bone mineral density in kids, 26 children, mean age 7.32 years old. And what this study was looking to see, if you increase, they were all standing, they all participated in the standing program, but they took the control group and increased their standing time by 50%. What they found was the difference between the usual standing time and the control group. There was a net difference about 60% additional standing time. Remember, frequency, duration dependent. They found that the intervention group had a 6% mean increase in the vertebral bone mineral density. They didn't find an increase in the proximal tibia. The regular group stayed level. So what is the critical age for weight bearing? We all know that we gather bone mineral density from birth until up about 25 or 30 years old. And then we stop accumulating and we start reabsorbing. This happens to everyone. And they did a study, a systematic review of typically developing children and adults. And they found that 26% of your final adult bone mineral density is gained during the early stages of puberty. Within this, other studies have showed that the time where you gain the most bone mineral density is early childhood, adolescence, and young adulthood. And from all these studies, they found out that the critical years for gaining your bone mineral density is 11.5 to 13.5 years of age for girls. And boys, who are always a little delayed, it's 13.5 to 15.05. And it's at these times when you are going to get most of your bone mineral density that you're going to have for your adulthood. Once you turn 40, you're going to start reabsorbing. So if you don't have bone mineral densities like a savings checking account, if you don't have enough bone mineral density that you acquired in those younger years, you're not going to have enough to maintain above that 1.0 gram per centimeter squared level to reduce your risk of fractures. Now we're going to talk about hip health. And hip health, I think, is so important. We can make a difference in children that for years were never found because hip dysplasia does not have any symptoms. It affects 35% of all children with cerebral palsy. They're finding that GMFCF level 5s have a 90% risk of a dislocated hip. And if you want more information, there's another whole talk on the website on just on hip dysplasia, but let's see what standing can do. So 26 spastic diplegic children, GMFCF level 3. So they are standing, they are walking with assistive devices. The treatment group stood for over an hour a day in abduction. If you look at the early studies about standing and hip health, you will find that if it doesn't say so because we didn't know it then, but you'll find from the pictures that they're standing in neutral. And they were saying that standing did not make a difference. We've added abduction, and we found that abduction changes the forces within the acetabulum to promote development of the pelvis and the head of the femur. So they started following, this was a retrospective study, prospective study. They started them at age 12 to 14 months with a standing program, and they followed them until they were 5 years of age. The control group did not participate in standing at all. What they found with the x-rays at 5 years, that the treatment group's migration percentage remained stable at 13 to 23%. With migration percentage, it's how they measure hip dysplasia or hip dislocation. And you want to keep it below 30% because then you still have a functioning hip. Once you get past 30%, which means over 30% of the head of the femur is not covered by the acetabulum. At that point, you start having interference with the ability of the hip to function, including being able to sit appropriately, hygiene. So the treatment group maintained it well below that 30%, but the control group varied between 12 and 40%. So there was a section of them that went above that 30% and were proceeding to possibly hip dislocation. In this study, 269 GMFCF level 4 and 5. So the kids who are totally dependent and those that need assistive devices, ages 8 months to 7 years of age. In this study, we're actually looking at the amount of abduction. This was the first study that actually added abduction in, one of the first studies. And this treatment group stood in 30 to 60% of total leg abduction. So 15 to 30 on each leg. You never start at the maximum abduction. You want to start small and slowly work into it until you get to what's comfortable for the child. If you get to a point where you see the pelvis start moving, you've gone too far. You don't have the range of motion in that hip. The control group stood from 0 to 20%. So perfectly neutral to 10 degrees of abduction. In the test group, the MP, or the migration percentage, decreased 7% without surgery. It decreased 3.5% without surgery. The reason it decreased less with the surgery is because the surgery moved the hip into a joint and then it decreased more afterwards. The control group increased their MP 6.5%. We also know that even after you've had surgery, you need to continue standing because the pelvis and the femur are still developing and still growing, and they need the forces. Again, hip dysplasia, go to the other webinar. So let's talk about spasticity and what can standing do for spasticity. We all blame spasticity for everything. They blame spasticity for contractures, but we know that it's not the cause of contractures. What it does, or else anytime you're on an antispasmodic, your contractures would disappear, and they don't. We know that. What spasticity does is maintains the joint in a static position for extended periods of time. And we know that the body reacts to the forces we put on it. So if we don't move a joint through the full range of motion, what happens is the muscles accommodate and shorten so that they can maintain the mechanical advantage for the range that you're using. But spasticity is important because it affects motor control. It also is affecting the contractures by maintaining the joints. So what can we do with standing? I really like this study because it was done one 30-minute session of standing with 17 patients with spastic hemiplegia. They stood in a little bit of dorsiflexion. And what they found after 30 minutes was the modified Ashworth scale, which is how you measure spasticity, one of the ways, was decreased a full point. And after 45 minutes, it decreased a little bit more. They also found that the passive range of motion and dorsiflexion increased significantly. So we're getting them out of that static plantar flexion position. The other reason I think this is important is if you're in therapy and you're fighting spasticity to try to control it and you're spending all your time, what if you had someone stand a half hour before you started your session? Could you get better results because you were working with less spasticity involvement? This study was done with GMFCF level 2 and 3. So kids who are walking with assistive devices and some independently. Just because you're up and walking, you're not necessarily getting the amount of weight bearing you need and your muscle tone is affecting, especially spastic diplegics. So it was an ABA design, which means you take the data, baseline data, you do the intervention, you stop the intervention, take data again. So weeks 1 to 3, they had PT twice a week, which is typical for a child of that age. For the B weeks, so weeks 4 to 6, they had prolonged standing for 45 minutes a day, 3 days a week, and their regular physical therapy. They had a significant decrease in muscle tone during the standing phase. But like everything else with standing, when you stop it, you lose the benefits. So on the follow-up phase, the muscle tone, level of muscle tone had returned to prior. Same with spinal cord. I've always known throughout my career that if I wanted to decrease extensor spasticity in the lower extremity, I needed to dorsiflex the ankle. What I love about this study is that they also looked at weight bearing and plantar flexion, which is totally wrong in my opinion, or my beliefs, but they did it. They had 8 sessions on 4 days, 30 minutes of stretch or weight load. The stretching was done in supine with a max dorsiflexion brace, like your night splints, any brace that can hold you in max dorsiflexion. What they found after the 4 consecutive days is that standing had a greater reduction in spasticity. What I find is really intriguing is that the dorsiflexion had a 32% reduction in spasticity. The plantar flexion group had a 26% reduction in spasticity. So we think of all of our patients who are stuck in plantar flexion, and we're trying not to stand them because we're going to increase it with positive supporting and increase the tone. But what they found is that if you stood, even if you're standing in plantar flexion, you're going to get a reduction in tone. Can we, with that reduction in tone, get increased mobility and maybe withstanding in the prolonged stretch, get increased range of motion? I don't know, something to think about. They found that the group that just used bracing, which is what we use forever. I mean, AFOs have been around forever, and that's what we use for tone management, but they only had a 17% reduction in spasticity. By adding the weight bearing, which could be, we'll talk about the stimulation of the anti-gravity muscles. Could it be reciprocal innervation? I don't know. Now we're going to talk about range of motion. Since we found out how to reduce the spasticity, we're now going to try to work on range of motion. And they found for years that passive stretching is not effective. We've stretched kids forever and adults, and we're not making any gains. What they find more effective is a prolonged stretch in the elongated position. So with standing, you can provide that stretch the whole time they're in the stander. In this study, it was done for hip range of motion, 13 spastic diplegics. So they had adductor spasticity. Level 3, so these are your kids up and walking with assisted devices with small bases of support, and then a lot of times scissoring. They started it at 12 to 14 months of age, and they continued to 5 years. Yes, this is the same study we had before, but it's the results on range of motion. They stood 70 to 90 minutes a day during the weekdays, and on the weekends it was 35 minutes a day, but they were standing 7 days a week. What they found was by keeping them in the stander, even though they were walking, but by spending the time in the stander with the weight bearing, with the spasticity reduction, and the elongation prolonged stretch, they were able to maintain the abduction range of motion, which is so important for gait. You have a better base of support. For hygiene, we all know what tight adductors and hygiene can do. And for sitting, you're able to get a better base of support when you're able to abduct your legs. Range of motion, kids with CP, ages 1 to 2. Think of it. We do not always stand kids this young. You can start standing children as soon as 9 months corrected age, which is important both for deformities or contracture development in the lower extremities, but also for the hips. Some kids dislocate their hips by the age of 2. So if you don't start standing them for 2, you haven't given them the stimulation they need to effectively grow good structural hips. So this group, they were 1 to 2, levels 3 and 4. So some were up and walking with devices. Some were walking with more supportive devices. Group A stood 60 minutes a week, 60 minutes 5 times a week. Group B stood 30 minutes 3 times a week. Again, we're looking at duration and frequency of standing. After 12 months, they found a reduction of spasticity in the hamstrings and the hip flexors. What they also found in the group that stood more frequently for longer periods of time, that they had significantly improved range of motion in the hamstrings and hip flexors. We find having statistically significant improvements in the studies. Mostly the studies for standing is hard to do because of the low number of people, but they were able to maintain and increase the range of motion in the lower extremities. When we look at children, CPUP, which is the Cerebral Palsy Follow-Up Program in Sweden, which has been collecting data for about 30 years, doing a retrospective study, they showed that children with cerebral palsy consistently lose range of motion in their lower extremities starting at age 2, and it levels off at about age 14. Well, at age 2, children usually get their first wheelchair. And because they have mobility, they stay in the seated position. By staying in the seated position and maintaining the hip and knee in a flexed position, they develop the contractures and lose the range of motion. By adding standing, which gives you the prolonged stretch in the extended position, you can maintain the range of motion. This was a single case study. A young woman with spina bifida, age 9. You can see the pre and post after an 8-week standing program. She was ambulatory with loft strands. Her gait was very slow and very labor intensive. After 8 weeks of standing, she had significant improvement in her bilateral hip extension, abduction, knee extension, and right hip internal rotation. Not sure why one didn't. But she also had less energy consumption to walk, increased gait speed, increased standing balance. Unfortunately, she chose to stop standing, and within 3 months, she had lost everything. You need to continue the intervention of standing to maintain the benefits. I include this study because it shows it's never too late to try. This child hadn't stood for 8 years, as we find happens a lot of times that you change schools, they don't have a stander. So the 8 years he hadn't stood. At 15, they got him up. They slowly worked him into a stander. They got him up to 30 minutes a day. He stood 30 minutes a day for 15 months. Yes, it's a long period of time, but those contractions didn't develop overnight. You're not going to get rid of them overnight. They had increased range of motion in 3 out of the 4 lower extremity joints. One knee, they could not get a whole lot of range because there had already been skeletal changes to the joint. This is one of the original, and it's been done numerous times, numerous schools. And even if you're not doing it as a study, you see it if you work in a school system. When the kids are in school, you increase the range of motion. When they go home for vacation, they're not standing, they lose the range of motion. When we talk about Duchenne's muscular dystrophy, we're working with a group that once they go into wheelchairs and lose their ability to ambulate, their contractures progress very quickly. We're also talking about teenage boys who don't quite have compliance, shall we say? So in this group, it was only 4 boys. They stood 1.3 to 3 hours a week. 3 out of 4 of them were able to improve the hip or knee range of motion. None of them improved ankle range of motion. We're finding with Duchenne's kids that the plantar flexion is actually a compensatory technique, and they use it to get knee extension to maintain their ability to walk. Even when you're up and standing, that compensatory technique continues and you're not able to get the range of motion. What they also found from the standing was that they were able to maintain the bone mineral density in 3 out of 4 of them for the course of the study. With Duchenne's kids, because of the corticosteroids, bone mineral density is a significant issue because the corticosteroids are increasing the reabsorption of the bone mineral density. So to be able to maintain it by having standing is a great benefit to prevent future fractures. Those who've worked in acute care or chronic care know plantar flexion contractures for people who are bedbound are chronic. We've gotten better about using splints when people are in bed, but we're still not good. This study was done with adults with traumatic brain injury. They had a 6-week program. They had standing with E-stim and ankle splinting along with the standing, and standing alone. What they found was that the standing alone had an average of 3 degrees more passive dorsiflexion. I understand we're within the margin of error of goniometry, but that 3 degrees of increased dorsiflexion is so important, especially if you've got someone who is doing a stand pivot transfer. It gives you a flat base to transfer on. If you have somebody who is a wheelchair user, you can get the foot flat on the foot plate and decrease the pressure. Think of the people you have with plantar flexion and you have them in wheelchairs, and we get that pressure sore right under the ball of foot because they're right there pressing. By getting that 3 degrees, you can get more even pressure. If you accommodate the foot plates, either to try to accommodate the plantar flexion, you have gravity sliding them off. Again, ruining the positioning, moving the pelvis, and increasing the risk for pressure injuries along the pelvis. Usually it's the anterior ITs. As I said at the beginning, standing is not just for cerebral palsy and spinal cord. We find most of the research is done in cerebral palsy and spinal cord, but there's also research for others with other diagnoses. For progressive MS, they found standing 30 minutes a day versus just a daily exercise program. In 3 weeks, the standing group went to exercise, the exercise group went to standing. What they found was during the standing phase, they had significant improvement in the hip and ankle range of motion. Again, the ability to stand, do a standing transfer, and the ability to keep your foot flat on the foot plate. They also found a downward trend in the modified Ashworth scores. As we saw in the other study, standing can decrease spasticity. Again, ankle range of motion, 30 minutes a day, 3 times a week in dorsiflexion. They find for adults that 30 minutes a day, 3 times a week is the lowest threshold to get some benefits. 4 degrees in ankle range of motion for the same reason we want increased ankle range of motion. If you see, I don't know if you can see his foot, it's not flat on the foot plate. This one is. He's got a little bit of plantar flexion. So also see how that translates up to the hip and the knee, puts him into a pelvic obliquity. It's important to get the range of motion at the ankle, not only for ambulation or transfers, but also for positioning in a wheelchair and prevention of further deformities by asymmetrical positioning. Standing isn't static. It has effect on motor. You can gain motor skills, and we'll see some studies that show it. When you get up into standing in a supported stander, even though you've got supports holding you up and you're not, EMG studies have shown that there is an increase in the anti-gravity muscles. With that increase in anti-gravity muscles, you have an increase in your metabolic levels. They found that standing for anyone had a MET level of 1.5. Why that's important is because sedentary activity threshold for METS is 1.5. If your metabolism is below 1.5, you're considered sedentary. We know through the past years, we've been talking about sitting is the new smoking, to quote my colleague, that we need to increase our activity levels and decrease sedentary behavior for overall health. What this study shows is that for children and adults, so children GMFCF level 5, adults who are severely dependent, by using passive standing in a supported stander, you can increase their metabolic activity to that of light activity. So you're breaking up the sedentary behavior for overall health. When we think of motor development, we know it starts in supine, sitting to standing. We know that you need to start the next level before you can completely finish the level before. An 18-month-old child, GMFCF level 5, 5-day-a-week standing program. By just standing, they increased his motor scores from 28 to 37 on the GMFCM 66. They also noticed an improvement in head control, upper extremity function, sitting balance, and ability. Again, by enabling him to assume and maintain the upright posture against gravity, you're stimulating the vestibular system, the proprioception, the visual system, and thereby enabling him to learn motor skills such as sitting balance, because he's able to practice it in a safe environment, and they translate back to the level below. Same with children with spina bifida. Standing 2 hours a day for 8 weeks, they increase their trunk impairment skill. They increase their gross motor skill. These are 3 to 17-year-olds, so they're in that period where you're gaining your motor skills. They had no change in the PD-FIM, which is the functional independence measure, probably because of the paralysis level. Again, MS, use it for people other than spinal cord and cerebral palsy, or kids in general. Significant increases in the amended motor club assessment. The amended motor club assessment is an assessment specifically for MS. It's used mostly over in Europe. There are some places that use it here, but they had significant increases in dynamic sitting balance. If you have increase in dynamic sitting balance, you are able to interact with your world. You're able to not have to have the world come to you, but you can reach out, you can lean, you can get that glass of water out of the fridge, you can reach the sink and reach the faucets in the back. You have much more function by having better sitting balance, and you can get better sitting balance by standing and developing your postural control in a safe environment. I love this study because we all know in SNFs, or maybe not all SNFs, SNFs I've been in, you get up, you get out of bed, you have breakfast, and you sit in the hallway in your wheelchair. This group started a 12-week physical activity program in standing. They did some exercises, they played some games. 71 to 93 years old. It's never too late. They were able to find that they increased the strength in the FIM scores, the functional independent measure. But 60% of those who required assistance to move from sit to stand were able to move independently from sit to stand. Think of the sense of accomplishment and just self-esteem people have by not being dependent on other people. They were able to maintain standing for a minute. It doesn't seem like a lot, but if you're toileting, that minute of independent standing is precious. You have time to do the hygiene. You have time to manage the clothing and not worry about the person collapsing on the floor. Those that were walking were now able to walk 14 minutes with their walker. They increased their strength and their functional abilities by participating in a static standing program. We never think, or very few, I never thought, I stood people with strokes and they all lean over to one side. Using a standard for a stroke patient just never came to my mind. Luckily, people are doing it now. And they added the standing, and they had significant changes both in the Berg balance test. Balance is so important. If you don't have adequate balance, you don't move out of your base of support, you don't interact with your environment. And the Rivermead motor assessment. So increase motor skills by adding standing. What they find with adult cerebral palsy. So we all know when you have cerebral palsy and you're under the age of 21, you have services, you have equipment, you have what you need. You hit that magic birthday of 21 and everything decreases. They found that adults with cerebral palsy who maintained a standing program 30 minutes a day, 3 days a week, again, adults, 30 minutes a day, 3 days a week, were able to maintain independent head control for greater than 30 seconds compared to their non-standing counterparts. They also were able to maintain a functional stand pivot transfer. Again, it's easier, faster, and promotes self-esteem when a person isn't dependent on someone else. Standing can also help people who are up and walking. Just because they're up and walking doesn't mean standing isn't going to help. 6 children, 6.5, ABA, they stood, they stopped standing. What they found was they had increased stride length, increased gait speed, decreased stance and double support time. They were learning from being in the stander how to stand and have postural control in the upright posture, which enabled them to have better gait. Stroke, again, getting them up and standing, you've got them. We all know strokes go to the non-affected side. A stander actually positions them symmetrically so that they learn to control their whole body and alignment. Balance scores increase. We're finding that they're using standing or elevation, verticalization, they call it, in ICUs much more often. Some are using tilt tables. I was speaking with people in the Midwest who are actually using our standards. And what they found that if you get somebody up, they're more alert, they make better progress. And this, they also studied weaning from mechanical ventilation. They stood daily at they started at 30 degrees and then slowly went up to 75 degrees and stood for about 30 minutes. Depending if they had orthostatic problems, they stopped the standing. But what they found that there were increased scores on the Glasgow Coma Scale. Ooh. They also found the Richmond Agitation Sedation Scale scores increased. Recently, I was working with a therapist out in Washington State who had a standard denied for a teenager with a TBI because there was no conclusive research that standing would help someone with a TBI. There is for CP, but he had TBI. So what they did was they had a report from the behaviorist and the study, because when he was in the stander, his agitation decreased. He was able to interact because he wasn't as agitated, and that enabled the stander to be approved. Pusher syndrome. I hated it because when I was in the rehab hospital, my job was to get custom wheelchairs for anyone who needed and to build them. Pusher syndrome people broke all my hardware. We all know they're all over to that side. And it's hard to clear it. They started standing, they worked him up to 30 minutes. Once it was up to 30 minutes, they they took the stander out of therapy and went back to his residence. On the day of admit, he had a Berk lateral propulsion scale of 11 out of 17. So moderate pusher syndrome. In 24 days, he had cleared pusher syndrome. 66% of people at his level clear pusher syndrome in 5 months. He also increased his FIM, his ability as functional independent measure. He was able to do more for himself in 24 days. Given our short lengths of stay in acute rehab, we need to use every tool we have to facilitate improvement and decrease the time. Standing did it in this point. When we think of respiration, when you sit, everything's squished. If you want to know more about respiration, there's another whole hour lecture on it on our website. 15 adults intubated and mechanically vented less than 5 days. They tilted them. They got them up for 5 minutes. And during the time they were tilted and immediately after, they increased the minute ventilation, their tidal volume, and their respiratory rate. It's exercising the respiratory system by getting you out of the dependent posture. We don't think of circulation. We don't have studies that are scientific. We have more survey studies. And what they found was that 42% of the respondents reported reduced swelling in the lower extremities. 74% had improved lower extremity circulation. Remember, standing activates the anti-gravity muscles. So we get the muscle pump going in the lower extremities that wasn't working when you're sitting. They also found that you could have increased heart rate during active exercise with support. We all know you need proximal stability to get distal mobility. The stander provides you the proximal mobility, either through an upper extremity ergometer, different exercises, or in this case, the glider, where not only do you get the upper extremity and active movement to increase your heart rate and aerobic capacity, but you also get a passive stretch on your hand, on your lower extremities. Bowel and bladder. The two most common problems with people who have neurological impairments. They were 10 subjects, 19 to 56, incomplete SCI. What they found was after they started the standing program, the levels of calcium excreted in the urine had decreased. Why is this important? Because when your body reabsorbs your bone mineral density, it's excreted as calcium in your urine. By adding standing, they were able to decrease the calcium in the urine. So therefore, you could say that they decreased the rate of bone reabsorption. There are many studies done on bowel and bladder. In bowel, you find that a lot of the studies are inconclusive. 2 individual case studies. GMFCF level 5 child with cerebral palsy. She was 5 years old. She needed stimulation for any evacuation. They started a standing program. From day 1, she didn't need to be stimulated again. 62-year-old male, spinal cord, had frequent impactions. He was on narcotics. Those of us who work with individuals with chronic pain, know that there is that narcotic constipation. So you include the Marilex, you include the suppositories. What they found was standing 5 days a week increased the frequency of BMs and decreased his bowel time. Surveys of users, 2 to 86 again, same survey, standing 20 minutes a day, at least 20 minutes a day. 50% reported improved bowel and bladder function. 43% had improved digestion. 21% had improved bladder emptying. With improved bladder emptying, you can get decreased UTIs because you decrease the environment for the bacteria to grow. By moving from sitting to standing, your bladder pressure is increased. If your bladder pressure is increased, it's easier to empty your bladder. That was a quick run through the scientific research, but I end with this quote that although experimental evidence is limited due to many factors, lived experience and cohort data suggest that successful integration of standing programs into age-appropriate and meaningful activities may enhance function, participation, and overall health. The scientific research is not high level, it's not plentiful, but the lived experiences and people's reports of what they get from standing is huge. I want to thank you, and any questions?
If you have any questions, please be sure to put those in the chat or the Q&A. But thank you, Marianne, and thank you everyone for attending today's webinar. We put the link to the course slides in the chat, but we'll post those again one more time. But they are available to you. Obtaining your CEUs should be relatively easy after the webinar. So to receive your credit, you have to complete the survey at the end of the course. So the survey should automatically populate in your web browser when you exit the webinar. If it doesn't populate, don't worry. You should get a follow-up email from both Ultimate Medical and Zoom within approximately 24 hours. And that'll have the link to the survey. If you don't receive an email in the next 24 hours from either us or Zoom, please check your spam folder, and it might be there. Otherwise, please reach out to us. Once you complete the survey, your response will be verified by our education team. A certificate of completion will be emailed to the email address you used to register for the webinar. Please keep in mind we do this manually, so it might take a few business days. This course is going to be available on demand soon, along with the rest of our entire catalog of on-demand CEU accredited courses available to you for free. If you or someone you know would like more free CEUs available on your own time, be sure to check out ultimatemedical.com/education. Again, thank you for your attendance this morning for our webinar. We hope you enjoyed it, and we hope to see you again soon. If you have any questions at the conclusion of the webinar, please don't hesitate to email us at education@ultimatemedical.com. And with that, I'll turn it back over to Marianne for some questions I see coming into the chat.
Thank you. And I also want to say thanks to everyone. It's nice to see some familiar names and people I haven't seen in a long time. Melinda, what decision-making would you use discontinuing a stander? Increase low trauma fractures. If somebody has developed low trauma fractures, if there are pressure injuries that we can't accommodate, but most of the time we can, I wouldn't discontinue a stander as long as it was continue to be safe for them to do it, because of the multiple benefits of standing, not just the ones we talked about here. Development of severe hypotension, any medical that is being either triggered or increased by standing, which I haven't, but I would continue standing as long as it's possible. Sometimes you do have to discontinue just because of the caregivers, especially when you get to the older population with older caregivers. I would only discontinue it if it became unsafe. A lot of messages. Oh, at what point does hip positioning into hip abduction not matter anymore? If you read the research on hip dislocation dysplasia, they say at about 8 years of age for the hip formation. By that point, the formation of the hip is pretty stable, but it also depends on skeletal maturity. And we all reach that point differently, and certain diseases and syndromes have it delayed. If there is adductor spasticity, so adductor spasticity, I would keep standing in abduction as long as I could. There is a height range and a weight range for most standers that have abduction, mostly because of the mechanics and physics, and I wasn't good in physics. But as long as you can keep them in abduction in a standard that will meet their needs, I would keep them in abduction. especially for the spastics. You never really want to stand in complete neutral. You always want to have a little. Think of it. Do you ever stand with your feet together? No. You want to have a little bit, but I would keep them in abduction. For hip, it's around the age of 8.
Mary Ann, we
Right.
have another question here that says, when is standing no longer viable contracture wise? When do you raise the white flag and determine standing is no longer safe?
Funny you mentioned that. There's if you are trying to get standing to manage the contractures and do the prolonged stretch, there comes a point when you don't go from an intervention to improve, but you go to an intervention to maintain. With a sit to stand stander, you can go, they can accommodate to 90, but you're not standing at that point. So as long as you can get them up and open a little bit and stand, I would stand them in a sit to stand stander. In a linear stander, it gets hard. And if you look at most of the linear standers on the market, they say they accommodate up to 25 to 30 degrees of hip and knee flexion. But with a sit to stand stander, you can go past that. If the contractures are so bad that you're not getting any stretch, any position change, then I would stop. But the benefits of standing and being upright, if you can get some standing, I would keep them standing and use the sit to stand if you have any contractures over like 30 degrees.
Try to help read some of these out for you, Mary Ann, because there's quite a few questions. I recommended standing to a client and mom was worried it would take too much energy and take away from her growth. Any thoughts?
It shouldn't take too much energy if you're in a supported stander. It won't take away from her growth. As we saw, it stimulates bone growth and length, also enables to have the stretch so that you don't have the mix match between the muscle and the bone. Don't go for 30 minutes. Start slow, work it up. The body's not used to being in that position. You need the body to have time to accommodate and adjust itself. I would still do it. I would say, but is the energy her energy or the child's energy? If it's her energy, that's a hard battle. But if it's the child's energy, yes, they're going to be tired, but you're tired after any time you exercise. You recover, you start slow and move slowly. All right, sounds like the more standing time, the better if tolerated, especially in times for 3 to 16-year-old. If you're looking for hip health, it's a minimum of an hour a day, 5 days a week, 2 hours a day, 7 days a week is the best. Anecdotally, there's no research on that. 60 minutes a day, doesn't have to be all together. 3 to 6 years old, if you could get 60 minutes a day, break it up. If you watch some of the other presentations you'll see the dosing, or email me and I can send you the dosing for each specific. Rule of thumb, an hour a day, 5 days a week.
Have you gotten standards approved for home use in adults post CVA?
I haven't tried. I haven't been in home health with CVA patients for many years, and I haven't tried. I've heard from therapists who have. I would be happy to help you with the LMN and the references. Just email me, but I haven't done it myself.
I think one of the most important things if you're trying for that population is really using your outcome measures to justify why supported standing would be needed. So their Berg balance scale, are they ambulatory? What is their, 10 meter, 6 minute, those types of things to justify that that individual is not standing safely or appropriately on their own to help support you with some evidence for your documentation.
And for those of you who don't know, that's Kristen Czat, who's the other clinical educator here at Ultimate. Is there a risk of hip dysplasia in children with spina bifida with very low tone? Yes, 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 yes. Huge risk. Hip dysplasia is not just spasticity, it's low tone. Hip dislocation is the #1 orthopedic issue for adults with spina bifida. But if they're not standing and they're not weight bearing as children, they're not developing the hip. So if you do, it's very important. And if you have case studies, let me know. I would love to see some more. I'm working with a therapist out in Idaho who has a practice just spina bifida kids, and she stands them all. She starts them standing right around 10, 11 months. No. Hip abduction is only available in linear standers. It's mechanically impossible to do it in a sit to stand stander. Is there benefit for being upright in a device that doesn't provide weight bearing if the contractures don't allow for positioning in a standard or start a standing program? There is benefit to being upright depending how bad the contractures are. In a sit to stand stander, I would try it. If you can get some weight bearing on the legs, any change of position. I don't have a really good solid answer for that. I would try it. But please feel free to email me and we can help you. Kristen, I can help you. Stander and a walker. The age-old question. The reason is there's a law that says duplicate equipment. There's actually a podcast on standers and gait trainers. They're not mutually exclusive. Depending on the insurance, and this is just me and what I've done for years, you get the stander first, and a few months later you get the gait trainer. Because if you get the gait trainer first or the walker, they're going to say that it's duplicate equipment because it's a weight-bearing device. What you can try, and it's been successful, to explain the differences between standing in a walker and standing in a stander where you have symmetrical positioning, prolonged stretch. In a walker, you're usually sitting, you're not weight bearing, you're weight bearing on the saddle. But listen to the webinar. It's a podcast. You can find it on our website. And my best results have been to get the stander first, say they've improved and they're now ready to walk, and then get the walker because it's a change in status. I think that's all the questions. Oops, there's one in the Q&A, sorry. What type, we typically brace kids when standing, but now wondering if we should try without braces and incorporate dorsiflexion. I've done it. My main thing about standing with braces and without is if you cannot get a good alignment of the foot and the ankle without the brace, you need to have the brace, because then you'll just be reinforcing deformities that are already starting to occur. If you can get a good alignment without the brace and maintain it during the standing, I would try to stand without the brace. Anything else?
I think those are all of them, Marianne.
Cool. Thank you guys. Oops. Thank you so much for participating and joining. Please go to our website and see what other courses we have available for both Kristen and myself. There is the podcast. There's a group of podcasts available now, more coming. If you have any trouble, you should get the survey today, right, Sam? And then tomorrow a follow-up email. If you have issues after that, please email education@ultimatemedical.com. I think we'll stop the webinar. Thank you guys all for coming, and we'll see you at the next one.